So I'm Gosia Gasperowicz. I'm developmental biologist in Calgary, and I'm a member of Zero COVID Canada uh, and coronavirus as well, and Protect Our Province, Alberta. I would like to talk about what tools we can use to suppress and eliminate COVID and why elimination is important. So since like 1.5 years, I was observing the spread of the virus and its dynamics. And the most important thing and feature of it is that it's all or nothing. Like if it is present and the conditions are good for it to grow, it will grow. If conditions are bad to grow, it will decrease. If we stamp it out totally, it cannot grow anymore. So it's like, for example, melanoma cancer. If you have 5 melanoma moles, cut 4 of them and leave just one, you are still in danger of having metastatic cancer. The same is with wildfire. You need to put the fire totally down, not to risk a widespread. So it's policies that make waves. So we have, like in Alberta, we could have eliminated it after the first wave, but we reopened at 10 cases. And then over summer, the cases were growing, then schools reopened, then we had the growth. Then there was some suppression, some measures put here, cases went down, but again, we reopened, again, another wave, again, some measures, again, we went down and reopened and dropped almost all restrictions, all measures, and started growing again. But we never went to zero. So, but if there are jurisdictions that have elimination strategy, and in Canada, it's Atlantic Canada, so 4 provinces that followed elimination strategy. So there are these colorful lines here, and 6 provinces followed living with the virus, so mitigation strategy. So those gray lines. So basically, living with the virus or mitigation strategy is that decision makers react when the wave starts or is already in the full bloom, and hospitals are getting overwhelmed. Then some restrictions are introduced. And then again, when cases are lower, they reopen again. They stopped restrictions, and then they put restrictions when hospitals are at risk. And that's the effect, like big waves. While elimination strategy and tools that were used to have it in Atlantic Canada work super well. So Atlantic Canada, each province at the beginning of pandemic closed its borders. So protected from importation of new cases. They had mandatory quarantine for everybody coming from outside the province. They had also internal restrictions like shutdowns to drive cases down. They also closed the schools. So they drove the cases down. They stopped community transmission. So they had 0 community cases, and they loosened the internal restrictions. They kept the borders controlled. And then at some moment, they reopened to each other. So people could freely travel without quarantine between those 4 provinces. And it stayed more or less like this for the whole summer 2020. They had little imported cases, little outbreaks that were stamped out. Then when all of the Canada had other big provinces had second wave, there were some outbreaks in Atlantic Canada, but they were stamped out. And because already they put travel restrictions between each other, so those outbreaks didn't spill over to other Atlantic provinces because of quarantine. Here was another big outbreak, but it was also stamped out. So they had outbreaks, but they didn't have waves. And interesting thing here is also how much the waves are made by policy, and the hospitalizations are need for hospitalizations is because policies. It can be seen as an example of New Brunswick, that sometime in summer they decided to live with COVID. And then you can see that they had so many more, they tolerated cases, they tolerated spread, and had so much more cases than other Atlantic provinces. And so cases translate to hospitalizations and deaths. So that's a very sad picture. We have, again, here deaths adjusted per population, so number of deaths per 100,000 people. We see this gray living with COVID provinces, how many people died here, much less people in Atlantic Canada. And recently New Brunswick, that has started to have the same mitigation living with COVID policy as 6 COVID provinces, started to have as much deaths as those provinces that live with COVID. So elimination strategy is better. It was proven that it's better than mitigation strategy on different aspects. So of course, for the health, it's much better. Much less people die in elimination following countries than mitigation following countries. It's also better for the economy. So the decline in GDP was much smaller in elimination following countries than mitigation following countries. And also it's better for personal freedoms. People have the lockdowns. So this shows the stringency of lockdowns. So the higher, the worse. So actually countries with mitigation strategy have stronger limits on movements because they have to deal with the big waves, while overall elimination strategy following countries have much more freedoms inside those countries. And now I would like to talk about vaccines and public health measures and combination of those two measures, two things, two tools to suppress COVID. So first of all, I would like to just brush up on what is R value, R0 and RT. So R0 tells us how many people on average one infected person would infect with the virus if there would be no public health measures and no vaccination, and everybody would be susceptible. So for original variant, it was around 3, and now we cultivate the Delta variant, so it's between 5 and 8. So this new virus, new variant spreads much faster than original one. And RT is R value, so how many people one person on average one infected person will infect on average under certain conditions. So under certain public health measures and vaccination and amount of infected people in population. So if R is below 1, it's good. That means that one person infects less than 1. So eventually the epidemic might die out. If it's above 1, it means that it's growing. So here it's mathematical model, just simulation of what would happen. So here we have daily new cases and time in days. If we would have original strain with R0 equals 3, then how many vaccines we would need, how many people we would need to vaccinate with vaccine that is 93% efficient against overall transmission to get R below 1. So if we would have 75% total population vaccinated and the vaccine would be 93% efficient, then we could drop R from 3 to 0.9, which is just below 1. So it would be very slow decline in number of cases. But what we really did with public, so it's just theoretical. We didn't have vaccines last year. But what we really did with public health measures, we dropped R value from 3 or whatever it is. We really don't know what is R0 of original variant. So that those 3, 6, 8, they're just estimates. But from whatever it was dropped to 0.5 to 0.7 that are observed R values in many jurisdictions. So we were able to really rapidly, just with a bundle of public health measures, to rapidly decline the number of cases. If at that time we would have such vaccines like here and so many people vaccinated, we could reduce R value to even smaller together with public health measures and stop the transmission in 2-3 weeks. But we didn't have vaccines then. And we let the virus spread and we let the virus mutate and generate new variants. So now we have a Delta variant that probably has R0 of 6. So doing the same calculation, the measures that, because it's twice more transmissible, so the measures that resulted in R value of 0.6, now it would be 0.6 times 2, so 1.2. So with the same public health measures, we would probably not be able to stop Delta. And that's calculation for vaccines. If we would have vaccine that is 80% efficient against overall transmission and have 65% total population vaccinated, I have no public health measure, no modification of our behavior, so behave like it's 2018, then we would be able to theoretically bring our value from 6 to 2.9. If we would vaccinate more people, it would be to 1.9. So vaccines alone, if we would open everything, wouldn't be able to stop the spread, to get us to herd immunity. But if we combine this, so public health measures, with vaccinations of this type of efficiency, then we can bring our value to below 1 and really strong below 1. So here it's our value, it's theoretical, to 0.58. And then we can get down from 100 daily new cases to 0 in just 35 days. So, okay, that are theoretical calculation on a basic vaccine and herd immunity math. But what is in reality? So we have the proof from Denmark and other countries that it's possible to crash Delta, although it's so much more transmissible. But with combination of public health measures and vaccines, they were able, and not only in Denmark, in other jurisdictions it was happening too, they were able to bend the curve and result in decline in cases. So Delta is still beatable, and it resulted in halving of 14 days and R value of 0.82. But then Denmark lifted almost all restrictions, and here's the proof that vaccines alone cannot stop the spread. So at this moment, 76% of total population of Denmark is fully vaccinated. So if they would keep restrictions longer and made them even a little bit stronger to make it faster, they could stop completely the spread, but they reopened. So I'm focusing on Alberta because it's where I live. And now we also proved that Delta is beatable. We bent the Delta curve. With vaccines, we are 68% people are fully vaccinated. When we bent it, it was even less. We have very, very delicate public health measures. We have vaccine passports, we have mask mandate, but any mask, so it's not even respirators, it's just any mask anybody wants to wear. And still, we have now R value of 0.84, and so it's going down, but it's going down slowly. So if we just continue what we are doing, getting with such R value to 0, it would take like 140 days, and no politician will wait 140 days. So what I expect that will happen is that in some moment, maybe in a month, we will stop dropping even the mask mandates. And actually today I heard that our cities want to stop dropping mask mandate. If we stop dropping the restrictions and measures that we have, like testing, tracing, isolating, and vaccine mandates and masks, we can expect growth again. So that's just copying what happened in Denmark. If we would have this doubling of 22 days, that's what we could expect. But if we do some more measures and get down from this 0 value, push the R value from 0.8 to 0.5 to 0.6, then we can stop all the community transmission basically before Christmas. And to do it, we have basically all the tools. So we need the tools to prevent introductions, so quarantine, tests, and vaccine passports. We need tools to stop community spread. So the most effective one probably would be shutdown. Like, they always worked, but it has to be financially supported, because people just cannot stay off work without money, without being paid. So it should be strong. I think that if governments could pay people for 6 weeks, 150% of their regular income, that would be great, and that could make it work. We need gathering limits and vaccine passports. And then we have a new tool. So we have vaccinations and boosters. We have airborne precautions. Now everybody knows that COVID is airborne, and we know how to protect ourselves from it. We have rapid tests, and of course, test, trace, isolate. So in wealthy countries like Canada, actually those three are low-hanging fruits. We can do it, and we don't do it maximally. We may maybe do 20% of what we could. So if we would vaccinate and boost as many people as we can now, so starting from people at high risk for severe outcomes and people at high risk for infection and transmission, that is essential workers, then we could reduce the spread. We could also do airborne precautions, so educate people how the virus spreads, improve ventilation, air filtration, and actually portable HEPA filters are cheap like borscht, and put wear everywhere indoors and 95 respirators. Use rapid tests, but not when cases go up, like use them when cases go down. So for going to restaurants, cinema, theater, at work regularly 3 times a week for everybody, and before private and corporate gatherings to screen out asymptomatic cases. So this we could do and really get to zero quick. Like in some jurisdictions, we can do it in just 6-9 weeks, like in Alberta. And then we could not only prevent the 5th wave, but we could also have safe Christmas. And then if many jurisdictions would do the same, they could reopen to each other, ease the restrictions of travel, and ease on quarantine. If we have two jurisdictions that don't have community cases, they can travel safely between each other. Thank you very much. So, do you have any questions?
How do you introduce vaccine waning in these models?
So my models are totally phenomenological. So I just observe what is happening somewhere else and extrapolate it. So I don't put, so they are not SIR, so I don't put internal variables. I just observe what is happening like in biology and.
Yeah. Thank you.
Thank you.
And what is the impact of vaccine passports? Is that a high impact or not such a high impact? Because we in the Netherlands have today in Parliament a huge discussion on vaccine passports because some parties say it will split society, other parties say it won't work so much, etc., etc. It's a huge discussion.
So observational in Alberta, like in my jurisdiction in Alberta, they worked. As soon as they were announced, introduced, and under funny name, I don't even remember what name, because they didn't want to call them vaccine passports. They made some way around it. Yeah. But anyway, so they were introduced, and immediately there was huge bump in vaccine uptake. Suddenly people started to vaccinate themselves more. And the other thing was, and our cases really started to go down, but it was combination of other measures too. But it seems that they work because unvaccinated people don't go to bars then because they cannot. So it at least somehow limits the spread. And it also made people go and get vaccines. So that were those two features. But yeah, I totally understand the ethical problems with that. And I would prefer that we would eliminate and not force people like that, like twist arms sort of by vaccine passports, but they worked.
And what is the role of companies in vaccine passports? Is it that they say to the employees, you have to have a vaccine passport?
Yes, so I think universities have now mandatory vaccination, and they have so if somebody is not vaccinated, they need to do tests, but they get more, they become more and more stringent about it. But it's not the government that decided about it. It's up to employers to to introduce the vaccine mandate de facto. And it's problematic because it totally generates some resistance. So we have a lot of frictions now about it.
Okay. Yeah. Well, we have them too.
Yeah.
Thank you.
Thank you. So, do we have another presenter? Is Martin here? Or Eric Feigl-Ding? No. So I can answer more questions, or I can maybe say one thing that I wanted to share about another tool that I thought a lot about recently, and it was a big kind of topic important in Alberta. So I think another tool that we can use. Okay, I share my screen. So another tool to eliminate is advocacy. And because our current response, so I would like to advocate for open source projective models, because our current response in many jurisdictions is mental models of decision makers, and we don't know what comes to those mental models. So jurisdictions need an open discourse about the way forward based on open source modeling by independent groups. And those modeling should include short and long-term projections, like for 3 months, 1 year, 5 years, and for various scenarios. So elimination policy scenario versus living with COVID policy scenario. And then all the stakeholders can get informed about decisions about the future and know what's gonna happen and what the risks they are facing. But it should be really open discussions. Like in Canada, we don't have open discussion about policy at the moment. So if we could advocate for that would be great.
Okay, thank you, Gosia. Eric is here, available to give his presentation. So let's, thank you very much. Let's make the switch. Eric, can you step into the speaker's chair over there? You can just drag yourself over.
Hi, everyone. Should I start you here?
Yeah, let me just put you into the speaker's chair. Are you going to do presentation? Or you're going to do?
No, I'm just going to speak for 15 minutes right now.
So let me just switch us back to discuss mode. There you are. And go ahead. Gosia, would you chair the session?
I think, unfortunately,
because
Gosia
I have to run to a different session in a moment in Alberta.
Oh, you have to leave?
Okay.
Yeah, I have to leave.
Well,
all right. Thanks, Gosia.
Someone else can chair. Carlos, you want to chair? Why don't you go ahead? You can start.
Okay. Hi, everyone. Good to be back. As I mentioned earlier during the opening statements, I think with COVID, in some people's minds on the way down, I think it's people think, well, it's over. Again, we're in the same kind of mentality that got us in trouble in the first place earlier this spring and early summer, when we see cases going down in the US and a few, industrialized countries, but we get complacent. And this complacency is a serious, serious problem, because what we know is that there is waning of not just the vaccines, but there's greater penetration of variants, these pole vaulting variants and high jumping variants that I mentioned before, as well as the waning of the so-called natural immunity, which, by the way, I really hate the term, because vaccines are not artificial immunity. Vaccines, it's still your natural immunity. It's just a training program for your natural immunity. And so please, I really don't like the term natural, because if they want, the other side wants to own the term natural immunity. Whenever vaccines, you are training your own innate and adaptive immune system, right? So yeah, I think, as Gosia was saying, post-infection immunity, the mass infection immunity approach, as some call it. And so I think we first have to call a spade on that. And second of all, that immunity wanes too. We've seen it in the Public Health England data. We've seen that after 180 days, reinfections of Delta soared after 180 days. That's undeniable. Just like vaccines have more breakthroughs, reinfections have more rates as well. And comparatively, we've seen data in Oklahoma showing that the reinfection rates are higher than breakthrough rates. And most recently, the CDC paper out last week shows that among hospitalized patients, the reinfection rates is 5 times higher than the breakthrough rates. So all else equal, these post-infection immunity, supposedly immune people, have 5 times higher. And more importantly, in the study, they matched on the exact duration. So the natural immunity, the herd immunity folks, they say, well, a lot of the people were, infected long ago, like last year. So I want to point out 2 things. One, they are admitting that it wanes, that after a long time ago, it wanes. And 2, they're actually wrong, because in the CDC study, they actually matched precisely based on the time of their last infection and time of the last vaccination. So it was an apples to apples comparison. And I think that should not be lost. And furthermore, I want to point out that there is something in epidemiology called surveillance bias or detection bias. And in lay terms, in this situation, we simply call it dead men tell no tales. And that is, and that's in the pirate lingo, of course. But what it means is basically, if you died, you're not here to tout your amazing immunity. While vaccinations, you vaccinate everyone, especially the vulnerable and elderly, but everyone. While among the natural infection, those who were vulnerable to COVID in the first place, many of them died, right? And those who survived are inherently just the survivors. While vaccines, you vaccinate across the board, and that's inherently apples to oranges kind of comparison. And furthermore, a lot of these natural immunity, past immunity studies rely on antibody tests. The problem with the antibody test, as you know, is it wanes, like the antibodies, wane over time. And many people who were infected have very variable antibody response. Some don't mount any antibody response. As we know, many immunocompromised people don't. And the dose is not the same. Like vaccines, you have a very precise dose. While with the previous infection, you could have a super high dose and therefore develop a super high antibody response, or very low dose and therefore you don't mount any antibody response, or very low. And again, it's very heterogeneous. It is not a very reliable method of saying I'm immune. This is why all the, when you travel and show a either vaccination or antibody positive test, that's not a really reliable metric. So, and again, it's only when they do these natural post-infection immunity tests, oftentimes when they compare, take those who survived, again, dead men tell no tales, and they take those who were exposed enough to mount an antibody response in the first place, as opposed to the low dose exposure ones or the weaker immunocompromised ones who didn't. So inherently, you're selecting for those who were gotten a really, really bad hit and were strong enough to survive it, the really, really bad hit. And now you're comparing across the board to vaccinated, who include the immunocompromised, the weak immunity, and whatnot. So it's a very bad comparison. In certain ways, that's what happened in the Israel study that supposedly showed natural infection survivors had stronger response. Yeah, because you're selecting for them from two different funnels. So I just want to first of all say that. Second of all, as I alluded to in the intro, with the vaccines, there is, as we vaccinate, we need to create the issue with all these stupid waves that come back and forth. And as UK has seen, UK's Delta is back on a resurgence, right? The hospitalizations are up, deaths are up, deaths are about to surpass their summer death peak soon. It's very worrisome. And why is that happening? First of all, UK, I want to remember that they had antibody tests, positive COVID antibody tests in 90% of the people in their April-May survey in the spring. And then Delta hit. And then, of course, vaccines went up higher. But yet, this case is still higher. The issue is that there is waning immunity. A lot of those 90% are now waned in terms of their strength. And so this is not like some lifetime immunity thing. It's pretty clear that COVID is not one of those diseases that gives you lifetime immunity. And the other issue is, of course, the waning. UK, after Israel, UK was one of the earliest to vaccinate as well. And so now you're seeing the waning. And so in many ways, as we approach winter is obviously has a lot more airborne indoor transmission, as we know. It's also respiratory virus season, compounded by waning natural immunity and as well as waning vaccine. We're going to basically give it, these partial speed bumps for the virus. And this is why it's still spreading. To stop it, we need to create a dam, a seawall that's high enough that's not these earthen dams that can be easily topped by a really, really bad wave, or be pole vaulted over by of evasive variant. And in certain ways, these evasive variants are there to spring up. And I want to also point out that generally, the more bodies that the warm bodies of the virus has to infect, the more chances it will develop mutations. Although that's just at a general steady state. The more warm bodies, the more mutation. But it's really accelerated among those who are immunocompromised. And also there's evidence of those who take monoclonal antibodies. There's lots of studies on that. But among the immunocompromised, lots of studies also show that the virus truly, really accelerates because it has a very interesting long-term safe playground for it to adapt and play whack-a-mole with the immune system. And in many ways, that's how we think a lot of these really bad variants arose. Also, this is also bodes poorly for countries in which has high HIV prevalence. And we know what HIV is. So obviously cancers and those transplant patients are vulnerable too in terms of immunocompromise. But HIV patients are extremely vulnerable, especially those without enough antiretroviral drugs available. And this is, again, very common in sub-Saharan Africa. And in certain ways, sub-Saharan Africa holds this double whammy where having a high HIV prevalence actually bodes very negatively. It could actually compound have this negative synergy with COVID in spurring new variants. And in certain ways, that's why we've seen two really bad variants, potentially the beta as well as the, slip my mind with the other new one if South Africa is, which has a lot of it, which is the most mutated variant so far. I think this is inherently the problem. And we have to really, really stop playing whack-a-mole, because playing whack-a-mole, I don't know if you guys know the game whack-a-mole. It's this game the kids play. You hit it with this soft hammer to make this mole go underground, right? But it doesn't actually, it's not kill a mole, it's whack-a-mole, so he goes underground, so you can't see it. You haven't actually solved the underlying problem. It's just suppressing it off the surface. And that's inherently what many governments are doing it. They're not going for elimination. They're just whack-a-moling it so that it doesn't look like it's a problem, so that the hospitals don't look that full, so that it doesn't look like they have a crisis story on their hands. And this is inherently this strategy in so many countries, that they just want to get it to a point where doesn't look like their political leadership is a failure, even though it is whenever it surges back. And this is why, to truly stop it, you have to have multi-layer strategy. The Swiss cheese thing we talk about. Another analogy is that you have to have the multi-layer castle defense. When you defend a castle, you don't just have one door. You have a moat around it, plus an outer wall, archers around that wall, and you have some murder holes with these, the hot oils that you pour down, and then you have the inner keep and inner walls and all that kind of thing. You have to have multi-layer strategy like the Swiss cheese or this castle approach. In addition, if we know that vaccines may wane, and although hospitalization efficacy stays up, again, the hospitalization efficacy, it's good, but it's not that great. It's about 90% among non-elderly, about 80% efficacy against hospitalization among the elderly. That's not good enough, really. Like, in terms of reducing the mortality or reducing the hospitalization by 80-90% for COVID, it's still a constant problem. But the problem of course, is that oftentimes the governments ignore that, hospitalization efficacy is good, but infection efficacy is mediocre for 40-30%. I see a question: how do we create the high seawall? I think it's, in a certain way, it's if we have a bunch of speed bumps and these earthen dams that can easily crest it, you're going to have this continual crisis. But we have to invest in the seawall, right? It's kind of like no one wants to invest $1 billion, $2 billion, $10 billion for a high seawall levy. Everyone just wants to spend only a smaller amounts just for the seawall because it's good enough for now. And earthen dam. But to build a high seawall, we need all these multi-layer strategy, of course, the premium masking, the indoor ventilation, and mass testing, in addition to fresh vaccines and boosters, and then immediately don't squander that. Immediately use all these layers along with quarantine, contact tracing, and everything, again, for shortened amount of time. Again, I didn't ever mention lockdown. And they do that together at the same time when boosters are fresh, right? All these other interventions are fresh, and then you make the seawall as high as possible so that whatever wave can come won't be able to crest over it. And whatever variant comes won't be able to pole vault jump over it easily, because variant could be escape variant against the vaccine, but it won't be escape all these other mitigations, non-MPIs, non-pharmaceutical interventions on top of it. And again, drugs, pharmaceutical interventions is not exactly, they're just hospitalization prevention. Hospitalization prevention is not the best strategy for dealing with a pandemic. It's stop the virus, not just merely hold the hospitalization back. So the seawall, again, fresh boosters with all these layers and mitigations at the same time, not staggered, not straggling, not very leaky, all at the same time, very, very robust, will keep it in check, and then get us to the zero that we really want. And I know this sounds very difficult, and this is why the pandemic is really quite a test for our collective social ability to work together, and for policymakers to do the right thing for public health in the name of protecting the economy. This is to protect the economy, not to kill the economy. And I think killing the economy is to have this nonstop nonsense coming back and back and back. And so I think that is my main message, that we should not rely on natural infection or focused infection of children, which is completely different, ludicrous topic in itself and wholly dangerous. We should build the seawall from a combination of vaccines, boosters, and all these other mitigations together for a short period of time. And then we will be able to hopefully defeat this and maintain that bubble of low COVID. And I think that is the best strategy. And it's, don't put all your eggs in one basket. Any countries relying on just vaccines and then reopening, and because most of our population is vaccinated, is not reliable enough. And one final word about herd immunity. Herd immunity, as we've heard, of course, this strategy is very, very risky, of course, especially if you rely on infection-based. But second of all, the theory of herd immunity assumes that, the analogy I give is you're at a dance party or a nightclub, dance party club, and someone on the other side of the room has it. You're not vaccinated, but you are on this side of the room and you don't want to get infected. But if 80-90%, 80-90 now because of Delta being so transmissible, of the room in the middle on the dance floor is vaccinated, then theoretically the chance of the virus hop skipping across the room through all these people to you is low, right? That's what herd immunity generally is. The issue is that's assuming perfect population admixture of vaccinated and masked people. What we know is that anti-maskers and anti-vaxxers tend to huddle in their own bubbles, and the vaccinated people and the maskers tend to huddle in their bubble. So among the super vaxxed and super masked and super precautious people, yes, the herd immunity effect is good, and their bubble is really, really high, 95% vaccinated or higher. But among the anti-vax, anti-mask, and they go hand in hand with a very large Venn diagram overlap, they tend to be very much anti-precautionary, and they huddle together in their social clique, and for the most part, other than holidays, which is inherently very risky. We always see the super spreading after family holidays. But they cluster in a group, and among them, the vaccination rates could be less than 50%, less than 25%. We see this in rural U.S. counties all the time, and inherently, there's no herd immunity among them. But even though overall you might have 75% of the population immunized, but they're not mixing. That assumes even homogeneous mixing. You see the same assumption with airborne transmission. You have to assume homogeneous mixing of the air, but oftentimes you don't have homogeneous mixing of the air when you have, say, a HEPA filter in the corner of the room that clearly is not filtering out all the air that's being sprayed out from the children or the teacher on the other side of the room. I've said enough, I think. And I think you guys get my point. I think the high seawall, multi-layer, multi-pronged, simultaneous approach, it's really key. Think of like a circus acrobatics of, all those people who they stand on top of each other, taller and taller, and then the guy, the person at the top holds up all these cups, and then one of them does this trapeze, and then they flip, and then someone else on the other side catches them. This is all very coordinated action for those kind of circus magic to happen. But in order for that to happen for us in COVID, that takes government coordination. And I hate to say it, the world is very uncoordinated. There's very large social divides of the herd immunity being this very unhomogeneously mixed. Okay. And unevenly adopted in mitigations, and governments refusing to act in a coordinated, simultaneous manner to create this high seawall, and that's why we're still here. And that's why I believe in the concept of elimination and zero COVID, but I believe the biggest barrier is not the scientific know-how, but it's the political willpower and the social behavioral willpower. So with that, thank you for listening, and welcome questions, or happy to defer to the next speaker. Thank you so much.
Why don't we take one question, and maybe two, but just one question. Who has a question for Eric? And some of the people cannot talk, so if you cannot open your chat and post the question in the chat. The chat can be opened by clicking on the talk bubble in the upper left. I'll just show it. Here's. So if you don't have it open, there should be some noise in the upper left, and if you click on that, you can put it in a chat into the side window. Does anyone have a question?
Yes, well, I'm Peter from Holland, Peter Spitters. If I hear your expose, you are very negative for the long term, and you haven't said something about the end game. The end game is political and economical, and a coordinated government approach. Well, these three issues are very, very difficult to manage and govern. What is your opinion about an end
Yeah, that's a very good question about the end game. So first of all, can everyone hear me?
Yes.
So the end game, I am cynical about the end game in different countries. I think the end game in most countries will be when the world gets vaccinated enough. But I think that's the best end game, plus, of course, mitigations. But I think the endemic end game, which many people are touting, and I don't think that they're wrong. I just think they have a different idea of how smooth the endemic phase is. And this is why I say we should still try to go for elimination. And there might be regional eliminations in some areas, but not in other countries. And that's what make me really, really sad as well. But some people have this fantasy that, endemic means it will be a harmless background virus. And then we'll live with the virus, but it's very harmless in the background. Very few people will die. I think it might go endemic, but I don't think it'll be as harmless as you think it is. I think it will be, certain pandemic flu years are actually really bad, right? We might just have a constant mini pandemic flu year after year if we truly accept endemic COVID-19. That's my worry. Yeah. And of course, the other end game is COVID-19 morphs into COVID-22 or 23 when another super, like a 3-point, even that's something that's even worse than Delta, because vaccines mostly work against Delta. But if there's another super virus that emerges that's much more evasive and more severe than Delta, then we're in real big trouble. But but that's a wild card. But if that doesn't emerge, I think endemic Delta will cause really, really big, because we know the natural immunity wanes. We know the vaccines, even with a booster, 2 shots, just for context, 2 shots takes you to about 700 antibody levels with the Pfizer vaccine. With a booster, so after 2 shots, the waning gets you to 300 to 400 on average. There's range, of course. And then the booster gets you to over 2,000. But the 2,000, assuming a 50 per month waning, you're good for like a year or two at a 2,000, 2,500 level. But it's not forever, right? And then will we need a booster after another year or 2 years? Maybe, but hopefully we can eradicate by then. But again, if right now booster adoption is expected to be lower than 2-shot adoption. At each level of the funnel, you're going to have less and less. And I think if we go endemic, it's going to be a lot uglier endemic. And that's the sad thing. I think we might end up in this really nasty endemic level where it's a mini flu pandemic year after year, as opposed to a truly innocuous virus that's kind of harmless.
Great. Thank you very much.
And that's the end game. And I'm a little cynical because I studied I study public policy and politics a lot, and I see the writing on the wall that it's not going to be pretty, and that if we choose that approach. But I think that's the way we're going, unless we have radical change to stop it.
Yeah, Eric, can you hear me?
Yeah.
Okay, great. Thank you very much. And we really should go now to the next speaker. In fact, Martin,
thank you.
We had a time change, and we didn't coordinate across the time change. So Martin, who was supposed to be the first speaker in the previous hour, I think we will have him speak now, and we will push. I apologize to everybody else who's waiting for the next session, but I think it makes sense to let Martin have the 10 minutes of his presentation and a couple of questions. So Eric, I'm going to take you down off the speaker seat. Well, here, let me just, Martin, I'm going to put you into the speaker seat.
Okay, thanks. And you'll need to tell me how to share my other screen so you can see my slides. And again, just apologies, everybody. We're in that couple of week period whenever the clocks in the UK change, but the US, they haven't. So we were just a little bit out of sync with...
Yeah, and honestly, it's my fault. I really should have recognized.
Oh, well, sorry about that.
Martin, if you don't mind just dragging yourself into a circle that's on the upper left where...
Oh, where am I? Where am I? Very good question. Sorry, I'm trying to find myself there. Can you see where I am? My camera is on at the minute, but I'm not seeing myself. Yanir, can you, I think you may need to help me with this. So I should be down there somewhere in those circles, should I?
I think you're already on the speaker's face.
Oh, am I? Okay, well, my camera's on, actually. So what do I need to do there to... Okay, that's switching it on. Oh, but it's not going on. Ah, okay. I may need to go to... Sorry about this. I may need to go to settings, camera. Ah, okay. That should work. Yeah. Okay. And how do I get my other screen on for the slides?
Next to the mute button, there's a little square to share the screen.
Yeah, square.
Share screen. Yeah. Got it.
So
yeah, okay. Can you see that?
You're good.
Okay.
Yes.
Great. Okay, Yanir, thank you very much indeed for inviting me. So what you asked me to talk about was lessons learned and next steps. And what I'm going to do is to talk about some work we've been doing for the past year and a half. And I was asked by Hans Kluge, the WHO Regional Director for Europe, to become one of the commissioners on this Pan-European Commission on Health and Sustainable Development. And this was the idea here was to look at how we would rebuild after the pandemic. And it was primarily people who were not from health. So it was chaired by Mario Monti, a former Italian Prime Minister and European Commissioner. We had another former Prime Minister, Helle Thorning-Schmidt from Denmark, a couple of former presidents, central bank governors, people from international agencies like Food and Agriculture, and so on, people from finance, with a few health people. And my role was essentially to be the rapporteur for the report. I chaired a scientific advisory board, and I essentially wrote an evidence review. And I hope you get a chance to look at the evidence review, because there's quite a lot in it. And I'm going to be summarizing our report and also what was there. The easiest way is just to Google Monty Commission and you'll find everything there. So what did we find? Well, we start off with an analysis, and some of you have heard me say this before, an analysis of what went wrong. And this is from something that Sandro Galea and myself and others did, which is to say that essentially the problem was that a country going into a pandemic is like a fleet of ships going through a storm. And what do we mean by that? Well, it means that if we're to get through to the calm waters on the other side, you need a captain who can provide decisive leadership. So that means that, for example, if you're in the United States at the time, you would have needed a president who believed in the laws of physics and didn't think that you could kill the virus by injecting bleach or ultraviolet light. Or if you were in the United Kingdom, you needed a prime minister who was actually going to the meetings and was engaged with things and not trying to leave the European Union and sort out his personal life. So that's the first thing. Then you need crew of the ship in sufficient numbers. The middle of a storm is not a good time to be going out and recruiting new staff. And then you need ships which have strong, secure, safe, are built properly. You don't want societies where all the safety nets have been torn, where people are living precarious lives and falling through the gaps in society in the same way you don't want them falling through holes in the deck of the ship. You need an ability to communicate with the other ships. You need a lookout, so you need a surveillance system, and you need to have the right chart. And by that, we mean you needed to have one which was based in coronavirus or SARS, rather than having one that was for influenza or Ebola. So with that, then what did we made a diagnosis. We said all of these things need fixed. Now, in the interest of time, I'm not going to go into them in any more detail, except it's obvious that we need to sort them all out. What we were looking at was looking forward. So what comes next? What will be the next thing to hit us as the human race? Well, it could be anything. You know, it could be another pandemic. It could be cyber attacks. It could be nuclear war. It could be an asteroid strike. And so it's many, many different things, and we need to prepare for all of them. So we need a comprehensive approach to threats to health, not just training people to be able to manage the next flu pandemic, because all sorts of other things could happen. And we thought we need to then put together a conceptual framework for understanding health. And at the heart of all of this, we said, essentially, COVID, like so many other threats to health, emerge at this interface between human, animal, and environmental health. Now, obviously, zoonotic infections are coming in here, but then we also have the non-communicable diseases with our agricultural system and our food production system leading to dietary problems, obesity, and so on. We have the built environment having an impact on mental health, and so on and so forth. So we need to look not just at humans, but we need to look at the other species we share this small insignificant rock with, and we need to look at the environment. And of course, we need to look at the microorganisms emerging all around us. But we've got all of those situations where health or ill health can emerge, but there are a whole series of things that we can do that either make things worse or make things better. So here we are on the right-hand side of the seesaw here, things that are going to help us, like peace, the dove of peace, justice, good food, shelter, fresh water. And then there are a whole series of things that humans can do that make things a lot worse. So our framework looks a bit like this. And here you can see One Health in the middle. We're on a planet. There are things that can happen to the planet that we can do nothing about, like a volcanic activity or an earthquake. And there are things that we can do something about, like global warming. We're in the middle of COP26, deforestation, loss of biodiversity, and so on. So those are the things that are going to impact on the health of the planet. Then there are all the things that make health worse that we can influence: conflict, terrorism, war, pollution, food insecurity, lack of shelter, irregular, unsafe employment, harmful commodities, the commercial determinants of health, hostile artificial intelligence, cyber attacks, disinformation, fake news, crime, corruption, racism, and xenophobia. It's all covered in our evidence review, so I'm not going to go into it. Then there are the things that we can do to make things better. And of course, we start off with the things in the Ottawa Charter: peace, security, clean air, water, food, housing, all the basic prerequisites of health. And then we move into what we call the social determinants of health, things like education and employment and working conditions. We move into health care, avoidable mortality, and so on, into social capital, social networks, and trust. And then the more modern determinants of health: access to the internet, digital access at a time when essential services are moving online, safe environments, the built environment, and access to justice. So that's our broad framing, and we take off from there when we look at how we're going to become prepared in the future. So what we do is we set out a whole series of recommendations to secure and promote One Health. At the national level, governments need structures and incentives and a supportive environment to work on animal, human and environmental health, health in all policies. Every minister is a health minister. And then we make a series of proposals to get people working together at the international level: the World Health Organization, Food and Agriculture, the World Animal Health Organization, and the United Nations Environment Programme, developing a shared understanding of One Health, agreeing common terminologies. Now, at one stage, we were close to proposing a World One Health Organization, but that was too radical, and we realized that wouldn't fly. So we pulled back a bit. But we do need some form of better working to create an appropriate international architecture. And that's our first major set of recommendations. But then as we go beyond that, we need to recognize that the reason that some countries have done really badly is that they essentially, COVID was shining a light on the fractures that already exist. And COVID was exploiting the precarious existence that people live. And we desperately need to do something about that. Now, what could we do in our commission? Most of these things need to be done locally or at national level. But what we were saying was that at least we can begin to get internationally comparable information systems that capture these inequalities. And in particular, we need to recognize that most of our work is colorblind. And yet the reality in many countries was that minority populations, people with dark skin and different religions and so on, were the ones who were most disadvantaged in the pandemic, just as they are often the ones who are most disadvantaged in real life. But the problem is that this is invisible. We have data on race in the United States and on ethnicity in the United Kingdom. We don't have anything in France. You've got some data in the Netherlands, some data in Scandinavia, but again, not much. So we need to be able to capture that. We need to be able to identify people in society who lead impoverished and precarious lives, recognizing that this has gone beyond rich and poor, because there are many people who are poor at one stage of a year, but are just above the poverty line the next time. The whole issue we're facing is precariousness. People who say, in next month, will I be in work? Will I have an income? Will I have food for my family? Will I have somewhere to live? And we also talked about gender as well, and in particular representation of women, but we could go beyond that. We talked about innovation, and we celebrated the major advantages and the advances in vaccines, the recovery trial, so many other things that have gone on that have been really, really good. But we have to recognize that our systems of research and development and innovation often do not work. So we're creating Me Too drugs. We're not creating the antimicrobials that we need to combat resistance. We're not getting the drugs for rare diseases. We're not getting drugs for neglected tropical diseases. Why do we even talk about neglected tropical diseases? Why are they neglected? So we need to have research with a purpose, the way we did have during the pandemic. We need to have a partnership. We need to work with the private sector, but we cannot have a situation where the public sector pays the bills for developing drugs and pays a second time to buy them, with the private sector reaping the benefits. It needs to be a genuine partnership. And we need to work on our health systems to make sure that we have learning systems that can adopt innovation rapidly. We need to invest in strong and resilient health systems, and we write a lot about this. And we look at the need to invest in health systems. I'll come back to that in a minute. but we particularly need to value the health workforce, because we need to say again and again that it was the heroes, the health workers, who got us through this, many paying with their lives. Now, in England, there is a saying about the First World War. The soldiers were described as lions led by donkeys. And that is the reality in many countries, because the lions, the heroes, were being led by people who were incompetent or corrupt or whatever. So we need to invest in our health workforce, but we also need to look at making sure that they have the flexibility. And that means task shifting, and it means recognizing skills. It means not just putting more money into it without reform. So there's a lot to be done there. We need to bring health and social care closer together and prioritize prevention. But if we're saying we need more money for healthcare. So we've been saying this for years, but we don't get it. So how do we do that? Well, we build on work that I and others did back in 2005, making the case for health, investment in health as an investment in progress of nations. In the same way that we recognize that we spent money in education to promote economic growth and inclusiveness, we invest in the digital infrastructure, we invest in transport. And so we need to look at working with OECD and others to change accounting systems to promote investment. That is now happening. We need to incorporate health into economic forecasts. Whenever a country gets a AAA rating, that needs to incorporate its pandemic preparedness. If a country has not invested in preparedness for health threats, it should not get a AAA rating, because it is a high risk, and that needs to be included. And we need to make sure that when the international financial institutions go to a country, they recognize its preparedness and they value it. And if it's not prepared, they say, you have to be prepared. In the same way that we are looking, as the IMF does, we're looking at the liquidity of your central banks. We're looking at your financial systems. We're looking at your health systems. And we need to invest in global public goods. Again, I won't go into that now because we write a lot about that. And we need to increase the share of development finance for health. We need to improve health governance.
Yeah, I don't know how long you're planning to go, but
nearly there. Just one or two more slides. So we need to improve health governance. We advocate a global health board, now called the Global Health and Finance Board, based on the Financial Stability Board that came after the global financial crisis. The G20 has just agreed to take that forward in a task force. We need a pandemic treaty and a vaccine policy. And then just finally, we know that this won't be easy. Countries will have to accept shared sovereignty, but they do that in many other areas, like nuclear and biological weapons, international finance, where there are rules on counterfeit banknotes, but not counterfeit drugs, the law of the sea. So why not health? And with that, I will stop. So
Great.
Sorry again about the time.
Thank you. And there's one thing that I would pull on, which is you said that it would be too radical to make, or at least for your document, to make a One Health organization. Yeah. But maybe we are in the process at the World Health Network of starting that happening. And obviously, not only we hope that we will be able to operate in that space, but that you will be participating in these efforts. So does anyone have another question for Martin? Let's take one question. We are running late.
Yeah, sorry, that's my fault.
No, I'm sorry, Martin. I will take the blame on this one. It really is my fault. I should have realized when I found out that the schedule timing had changed that we had to switch your session.
If I may, I have one question.
Please, Peter, go ahead.
I'm from Holland.
Hi.
And I saw your VOC ships in your first slide.
From Hearn.
We are one of the most weakest in the chain of European governance. We think we can do it, but we are so very weak, and we miss European governance in governments attacking the pandemic, but also in our scientific advisory team. They lack European governance, international governance.
Yeah, I know. No, it is a difficult. I also am on a working group in the European Health Union. So, I mean, this is clearly high on the agenda at the minute. Um, it is probably a little bit easier because you've got rid of the British. Although Mark Rutte is probably the closest, maybe not, but I think the Netherlands also has an Atlantic perspective in all of this. I think it's fair to say, and you have seen that in the pandemic response. So it is challenging, and you have done much worse than Belgium, for example, in some ways. But there is clearly there is momentum here. Ursula von der Leyen is very clear. I mean, she is a public health doctor herself. So there is clearly a momentum there that is being pushed. There is leadership from countries like Germany, which is important. We need to see, obviously, what happens when Olaf Scholz
was leadership.
Well, yeah, but there was. But I think there may be as well. Maybe again. So I think we obviously have got challenges. We've got the French election coming up, but we have a really important driving force in Mario Draghi, the Italian Prime Minister. Mario absolutely gets this. And Mario, as chair of the G20, who is a very good friend of Mario Monti, has been taking this forward. And that's why we see so much from our report in the G20 document.
Okay, yeah.
So I'm quite hopeful, but I'm also not naive that there are challenges. The one thing that we need to really do is keep clarity on the HERA, the equivalent of BARDA, because there's a lot of confusion about that and what it will be. And many of us are feeding into that process to try to think, how do we actually design that? There's a lot going on, but yeah, you're right.
All right.
Okay, thank you.
Thank you very much, Martin. Thank you for coming. We really appreciate it, and outstanding work. And can we get a link to the brochure that you put out? Is it available?
Yeah, I can either post it but it just Google Monti, MONTI Commission, and it's the WHO Euro website. That's the easiest because the web address is so long I didn't put it on a slide.
Thank you.